Chris. Also, thank you very much for the introduction. My disclosures are down here, and I also have to disclose that I would have loved to take your position, my opponent's position. For some silly reasons, I messed up with the double negative wording in here. So in reality, I believe something else, but I'll try my best to go for that position. So one of the first questions is really, is that an issue at all in the treatment phase? Now we're talking about highly efficacious substances with a high relapse rate reduction. So, why do we care about relapse-led disability? The reason is still that, despite like an increase of, for example, Untitled treatment over the years in a large German cohort, the majority of our German MS patients still continued to have relapses, and this makes glucocorticosteroid treatment for relapses the most commonly used medical treatment at all still in the treatment area. So this is clearly an important question. Now, when we talk about relapses do not matter in relation to long-term disability, then I guess we have to divide, as my previous speaker did, between like the question natural history, relapses are not associated with disability and prognosis. And the second aspect is the effects of treatment on relapses appears not to translate into effects on disability progression. And these are different issues. I will only briefly touch upon the first aspect because you have already done that in depth. And I will try to bring 2 or 3 examples of the second issue. So really, we've heard about the, at least phase-specific lack of association between relapses and disease progression and prognosis from the natural history cohorts. I guess this is really the largest one, or at least this one used to be a landmark paper in the early 2000s, the French Cohort, where what you could observe was, when you asked what's the interval between EDSS 4 to 6, it was independent from disease course. So if you had like a relapsing phenotype or a progressive phenotype, it just didn't matter. So that still doesn't exclude that there may be an impact of relapses on disease course and disability. And so these authors of the French cohort study really focused on SPMS with and without superimposed relapses, and again, you just don't see any difference. Why is that? And I see that this argument is a bit artificial, but I told you I would have loved to take a different position, but at least I think it's a valid argument, but a weak one maybe. Maybe this is because in general relapses, or most of the relapses, are relatively mild and would not leave any major residues, as we've already seen in the old pivotal acute optic neuritis trial. The majority of the patients really had a very good improvement of the visual acuity. So the endpoint here in this graph is normal visual acuity and normal visual fields. And what you can observe in here, and this is really still influencing our daily clinical treatment paradigms of acute relapses, is that if anything at all, then IV methylprednisolone has a moderate or even only slight impact. So there's also some dissociation seen between the clinical relapses and disability when you look at newer studies, especially like the newer studies with highly active agents such as the AFFIRM trial with Untitled. And here the data, especially on no evidence of disease activity, or at that time it was freedom from disease activity, gives you some data, especially when you look at this cohort, no clinical disease activity. So how would that translate, and what would that sort of mean in detail? So when you look at the placebo arm, so the so-called natural history, then again you see something where you see a clear dissociation between relapse activity and disease progression. So there were few patients, or like the majority of patients had relapses during these 2 years of confirmed trial in placebo arm, but only the minority had disease progression. The same held true in the natalizumab arm. Also again, despite lower relapses, some patients did have relapses, but the minority had disease progression. And also, what you could observe when you cross-compare placebo to natalizumab is really that the treatment effect, the magnitude of effect on relapses does not directly translate one-to-one into the magnitude of effect on disease progression. So some indication for a dissociation of treatment effects on relapses A and disease progression B. And we've seen that in a more recent trial again, the CARAMES-1 trial. You know that this is the Alemtuzumab trial on treatment-naive patients, where you see a clear and profound relapse rate reduction in favor of Alemtuzumab compared to interferon beta-1a subcutaneously. But when you look at the EDSS progression, this effect is somehow diluted. So yes, there appears to be a numerical difference in favor of Alemtuzumab, but this fails to reach statistical significance. So the point I'm trying to make again here, therapeutically, at least in some stages of the disease, maybe not in these stages of the disease, there may be a dissociation between treatment effects on relapses as compared to treatment effects on disability. And we've seen that with Alemtuzumab much earlier, even in patients with inflammatory efficacy, activity on MRI, who later went on to develop disease progression. So what you can observe in here is, yes, you have a profound decrease of inflammatory activity as depicted by gadolinium enhancement after treatment with Alemtuzumab, so all the bars go down. But still you have a proportion of patients who continue to progress and who continue to develop brain atrophy. Again, this is the paradigm that we're talking about, the window of opportunity and the presumed and hypothetical dissociation between inflammatory processes and neurodegenerative processes. So why are we having this debate? Why do we still generate data which is not consistent? And you have demonstrated that very well, that we do have data either in favor or in contrast to our current hypothesis. This may have to do with the readouts that we're using. I have used these kinds of slides before in my last talk. I just wanted to bring it up again. So this is an old publication by Fred Lublin, who looked at what kind of residues do relapses leave. And what he came up with was there's a high degree of residues. So almost 40% of the patients had an EDSS increase of 0.5 or more. The caveat is, in this study, the follow-up was only after 2 months, and we all know that the recovery from relapse may last much longer. And really also another caveat in here is we just can't find out what percentage of the patients was treated with an active relapse treatment. An issue why I brought this up, and I have shown this slide before in my last talk, is when you only look at like 2 months outcome parameters or so, then you may be misled when you look at EDSS. Because when you look at short-term clinical trials, 2 years trials, when you only look at the placebo arm of 31 randomized clinical trials, then the likelihood to develop either 3 months confirmed or 6 months confirmed disability is as high, is exactly the same as developing 3 months confirmed or 6 months confirmed improvement of your EDSS. So the point I'm trying to make is, obviously during this stage of the disease, there's a lot of fluctuation, there's a lot of background noise. So this is also really the conclusion of the authors, which tell us that if you only go for short-term observations, then the data may rather reflect random variation, measurement issues, and issues on the relapse itself. Now, I went through these two positions, and I brought reasons in favor of that hypothesis that was brought up. I disclosed that this is really not my opinion. I would love to take the last 4 minutes that I still have to try to convince you that the topic is probably not, whether relapses are not as bad as we thought, but still relapses constitute a medical need, and that we still need an optimized treatment of especially severe relapses. So this is the NARCOM's North American cohort that you know. When you ask the patients about their improvement of the relapse symptoms, then the picture is quite disappointing, one has to say. So few patients say, yes, it's somewhat better. The majority would say, well, it's worse or no change at all. And the issue is, it really doesn't matter whether these patients were steroid treated or not. So there's some bias towards treatment, IV solomedrol treatment in the patients who became better in the end. But this is not, by far not a large treatment effect, isn't it? And this is actually reflected, obviously, in the NARCOM's cohort by the means and by the way how the patients were treated. So it was like observation only, that was the majority of the patients. Some patients used oral prednisolone, some used IV, methylprednisolone, dexamethasone. Some patients were even treated with ACTH, IVIG, name it, and you get it. So the question really is, why is it that steroid treatment is so poor in MS? And when you take extremes of outcomes, then you can divide between steroid-sensitive patients and patients who are resistant to glucocorticosteroids during relapse. And one hypothesis is the following. So in order for the steroids, glucocorticosteroids, to work in the cell, they have to dock onto a cytoplasmic steroid, glucocorticosteroid receptor. This glucocorticosteroid receptor is normally inhibited by a molecular chaperone, a cellular molecular brake of the receptor, which would be protein 90, HSP90. Only if the glucocorticosteroids binds to the receptor, then the brake, HSP90, will dissociate and the complex will translocate and elicit its downstream mode of action. And Kryselmai, almost a decade ago, from Poland, actually looked at the free steroid receptor and at the molecular chaperone, and what he found was, just as you would expect it in steroid-sensitive patients, there's a high concentration of free glucocorticosteroid receptor, whereas in steroid-resistant patients, there's a high concentration of the molecular brake. So the question really is, in order to overcome steroid resistance and to improve treatment efficacy of glucocorticosteroids, are there any means to improve and to increase cytoplasmic glucocorticosteroid receptor? Yes, there is. This is work done by a co-worker of mine, Robert Hutner. If we in vitro treat our T cells with vitamin D in ascending concentrations and concentrations that you can easily find in the serum and in the plasma, then you can easily observe that you, yes, of course, that you find a increase of protein expression of the glucocorticosteroid receptor. Is that functional? We tend to believe yes. So the classical functional assay would be T cell apoptosis induced by methylprednisolone. So these are the controls: placebo, vitamin D monotherapy. You apply methylprednisolone in concentrations that you will achieve in serum during relapse treatment, and you have an increase of T cell apoptosis. But you even further synergistically increase this T cell apoptosis when you treat the T cells with vitamin D and methylprednisolone, arguing for some synergistic mechanism. Would that hold true in vivo? And for that, we always use our EAE experiments, experimental autoimmune encephalomyelitis, So we do a typical relapse treatment like we do with the humans. So only when the animals have developed some symptoms, we treat them over 3 days, either with methylprednisolone alone, vitamin D alone, or with the combination of vitamin D and methylprednisolone. What you can clearly observe in here is that you have a synergistic superadditive effect in comparison to monotherapy, and of course in comparison to the control. So is that really dependent on the steroid receptor? For this we used T-cell specific mice who were devoid of the glucocorticosteroid receptor, and yes, what you can observe there is the therapeutic effect is blunted. Do we have any evidence that that may play a role in the human being, in the patients? Maybe. So we know that MS patients have lower vitamin D levels, that's clear. But in our cohort, when we compared stable MS patients and patients with a relapse, with an acute relapse, but further subdivided them into steroid-responsive patients and steroid-resistant patients, really the ones with the steroid-resistant relapses had the lowest vitamin D levels in the plasma measurable. So I come to the end. My opinion, my frank opinion would be relapses are associated with disability and prognosis, but maybe at a certain stage of the disease. The effect of the treatment on relapses does not reflect one-to-one into the effect on disability progression, which is probably true, but on one end it would be the window of opportunity, and in the CARAMES-1 trial it may just be too early, or the interferon may be strong enough in these patients. But clearly for me there's still a medical need to optimize our current treatment paradigm for acute and severe relapses, and an improvement of phase and stage specific efficacy. Thank you very much.